Hi, I'm Dr. Shakti, and let's discuss about concentration and dilution of urine. The first thing I want you to understand is, although this is a very beautiful topic to teach and a lot of good concepts are there, uh, when it comes to entrance, you have to, decide what to study and what not to study. And this is one topic which you don't need to actually understand too much in detail because it's not going to help you in any other subjects. Okay, so whatever is needed from an MCQ point of view, I'm going to describe that. Whatever is needed for you to understand the concept, nothing else. Okay, so let's start with the lecture. So two things you need to understand: what is countercurrent exchanger, what is countercurrent multiplier. The whole concept of countercurrent is there is two channels which are there. One is flowing in one direction, the other is flowing in the other direction. Okay, you take loop of Henle, one side is coming down, one side is going up. You take vasa recti, one side is going down, one side is coming up. So that is why it's called countercurrent. Next thing you need to understand that countercurrent multiplier is loop of Henle. Countercurrent exchanger is vasa recta. Why so is something you need to understand because you might get confused with the terms. So you take a look at the loop of Henle. There's a thin descending limb, thin ascending part, and a thick ascending part. So in the thick ascending part of the loop of Henle, each segment of it has your sodium potassium chloride channels through which sodium chloride is reabsorbed, okay, from the tubules. Now when that is taking place, this has the ability to create an osmotic gradient up to 200 milliosmol. Okay, so each level has a ability to create a osmotic gradient of 200 milliosmol. Now each time it passes through this, the tubule fluid passes through this, each level this happens and it gets multiplied on top of each other, 200, 200, 200, 200. That is why it is called countercurrent multiplier, because the osmotic gradient of 200 in a single segment gets multiplied more times as it passes through it. Now we have your vasa recta. It's called the countercurrent exchanger. So this countercurrent multiplier, which is loop of Henle, is what generates the osmotic gradient. Once it is generated, it has to be maintained. Okay, so your osmotic gradient is created. You have your hyperosmolar interstitial fluid over here. Okay, so that should not be washed out. That should not change because flow of water here and substances going through here and there. It should not change. Okay, so for that your vasa recta is important to maintain whatever was generated by your loop of Henle. Okay, so things can be absorbed and reabsorbed freely based on the osmotic gradient and kept in place however it was created. So that is why vasa recta is a countercurrent exchanger, because this is not permeable to some things and not permeable to some things, like thin and thick ascending limb. Yeah, this is permeable. Okay, so ideally the thin ascending and the thin descending limb is not permeable to solutes but is permeable to water. This is permeable to solutes more. Okay, so because of this, that is why there's a difference. Now we need to understand how dilute and concentrated urine are formed. So we'll take a look at dilute urine first. So initially in the proximal segments, your sodium chloride, water, everything is reabsorbed. Major components of them are reabsorbed in the initial proximal segments. And by the time it reaches here, you can see over here, it is 300 milliosmol. So it is pretty much similar to your plasma because, equal amount of sodium chloride and water getting reabsorbed. It kind of remains almost similar to your plasma. Now after this, what happens is what changes. Now what you can see is this descending limb of loop of Henle is impermeable to solutes but permeable to water. So water goes out, and because water keeps going out, the solute concentration inside increases, so osmolarity increases. So this goes to around 600 milliosmoles. This is dilute urine, remember that. Next, when this is going out, as I told earlier, now your sodium chloride comes out and your active transport So this is where your osmotic gradient is created. Okay, where more and more sodium chloride is taken out. So because of that, by the time it reaches here, you can see that the osmolarity has gone to 100. Okay, so this has gone to 100. So this is kind of similar. It starts in 300, it goes to 600 and comes to 100. Whether it is dilute urine or concentrated urine, for this 300 and 100, this won't change. Okay, and this is remaining 600 outside. The interstitial medullary osmolarity also 600. Okay, now from here on, when it's coming, the urine should be dilute. So water is not reabsorbed. You don't need water to be reabsorbed. We want dilute urine. Okay, maybe there's excess water here. Yeah, excess water in the ECF, because of which you need to excrete it out. Okay, so water keeps going out through the urine, but a bit of solutes are reabsorbed over here. So finally, you can see that the osmolarity comes to around 50 milliosmol. So very dilute urine can go up to like 50 milliosmol as per Guyton. Okay, it starts in the 300, 600, 100, 50. So what you have to remember is this comes to 600 inside the loop of Henle, and your medullary interstitium also 600. Okay, now let's take a look at concentrated urine. You'll understand exactly what happens. So now the only difference is in the ECF, fluid is less. So when the fluid is less, you need to conserve your water. You don't have to excrete all your water away because you need to conserve your water. So you need to concentrate the urine and release it. So for that, now because water is less in the ECF, something like ADH is released, vasopressin is released. So that becomes a major difference over here. What that ADH does. Okay, so you can see that this becomes 300, this becomes 100, just like earlier. Nothing changed over here. Okay, only thing that changed over here is this and some things that happened here. Apart from that, here and here, you can see that there's no much change. This became 1200. The gradient became 1200. From 300, the medullary interstitium went up to 1200. So what happened was that there's more sodium chloride reabsorption and it going into your interstitium, along with some substances like urea, which are getting transported. As for this to happen, your ADH is needed. ADH acts through urea transporter 1 and 3. Remember that. Through 1 and 3, it does this. So that is one effect of ADH. Okay. So because of this, your medullary interstitium becomes hyperosmolar. So that gradient has been created over here. Okay. Once that gradient has been created and it's coming out, next thing is your aquaporin channels. So through ADH again, through aquaporin 2 channel, every step over here, water is getting reabsorbed. So if you remember the earlier picture of dilute urine, water was not getting reabsorbed here. Hardly any. Okay, a bit of sodium chloride was getting reabsorbed, but water was not getting reabsorbed. Here, because of the effect of ADH through aquaporin 2 channels, water is getting reabsorbed over here, making it more and more concentrated. Okay, now in case questions come, apart from this aquaporin 2 and urine transporter 1 and 3, in the proximal parts, water gets reabsorbed through aquaporin 1 channel in the proximal parts, and urea through urea transporter 2. So ultimately it's actually A2, A1, A3, but so that's how it happens. Okay, so this is in case questions come from this. Okay, so the only difference is here ADH is there. Because of the effect of ADH through aquaporin 2 channel, more water is getting reabsorbed, making it more concentrated. Okay, and urea transporter is there, making it the medullary interstitium hyperosmolar. Because of that, here it goes till 1200, and here again it can go till 1200. So this is the next thing. So earlier in dilute urine, it can go till 50 milliosmol. In concentrated urine, the maximum you can go through is 1200. We don't have the capacity to make it more concentrated than that. 1200 milliosmol is the maximum you can concentrate your urine to. Remember that as well. So let's take a look at this diagram from Guyton. So initially 300 milliosmolar, it remains same. Now between dilute and concentrated urine, the only difference is this is 600, this is 1200. This is the loop of Henle. Okay, so 600 and 1200, and then again it comes to around your 100 value. But from here on, because of the effect of ADH, one goes this much, one goes this much, 50 to 1200. So that much difference is there. Okay, so this is what we're talking about. Okay, so this is 300, it will go to 600, 1200, 100 over here, and over here ADH, making the difference between them. You can see it better over here in this diagram. So again, this much, this is because of concentrated urine, dilute urine, it comes to around the same, and then it goes here, but moreover the difference is in the collecting duct, medullary collecting duct especially, where your aquaporin 2 channels come into picture along with the urea transporter. So that does everything. So 3 things that are needed for formation of concentrated urine. First, ADH should be there. Yeah. Second, the renal medullary interstitium becomes hyperosmolar because of urea and all that. Again, ADH also plays a role over there. Then the osmotic gradient that is created, okay, so it is generated by the countercurrent multiplier and it is maintained by a countercurrent exchanger. So because of all these 3 things, your concentrated urine is formed. Next is something about obligatory urine volume. So what it means is, our body has things that you need to excrete out. To excrete that out per day, at least this much amount of urine should be passed to excrete that minimum amount of substance we need to extract. Okay, so you can't concentrate it more than that. So that minimum volume is obligatory urine volume. So there's a formula for that. So the osmoles that is excreted per day, yeah, that is the urine osmolarity into the volume of urine output per day. So how much urine output per day into the measured osmolarity of the urine is how much the osmol that is excreted per day. So in a normal person, 70 kg person, usually will need to excrete 600 milliosmol per day. Okay, this is minimum. Okay, so in a normal person, 70 kg person, around 600 milliosmol per day needs to be excreted. The maximum ability for us to concentrate urine to is 1200. We had seen that earlier. So imagine it's 600 milliosmol per day and the person is going and using his maximum ability of 1200 milliosmol concentration. Okay, so we're talking about obligatory urine volume. That's why we're using this, the minimum that you need to do. So if you look at it like that, at least 0.5 liter per day should be going. So this is important in a clinical setting. If it goes less than that, means that's a problem. The person is not able to excrete enough urine. Okay, so the person is not able to excrete enough things that need to be excreted. So this is how you measure this. So this is the obligatory urine value. Now, sometimes the question comes, what if a person takes in seawater? What is the difference that happens here? So when you take in seawater, I told you, this is a normal by all the chemical reactions that are taking place inside the body, whatever, around 600 milliosmol per day should be what is excreted normally. Apart from that, you're taking in something very hyperosmolar, like seawater. What is going to happen? So on top of this, you need to excrete that hyperosmolar substance also now. For that, you need some water. So amount of water should be more now to excrete that extra osmolarity that you just took in. Okay, so for example, instead of 600, now the seawater osmolarity, say it comes to 1200 milliosmol per day. Maximum ability for a kidney is to concentrate it to 1200 milliosmol per day. So maximum it can concentrate 1200. Say the seawater itself has 1200. So to excrete that seawater 1200 milliosmol per day, you need to excrete at least 1 liter per day. This is only for that seawater we just took. On top of that, your body innately for that 70 kg person needs to excrete this much also. So ultimately, the person has to excrete 1.5 liter per day, taking both into account. So this is what you have to remember. So in case of seawater, you'll have to take in 1.5 liter per day. So this is another set of questions that can come. So the minimal amount of urine to excrete waste product in a normal 70 kg person. So that is the obligatory urine volume that we were talking about earlier. Okay, so that is 600 divided by 1200, so it comes to 0.5 liter. So that's 500 ml. So this is the answer. Minimum urine osmolarity achieved by kidney. So that, according to guideline, comes to around 50 milliosmol per liter. That is the answer. Minimum amount of urine to be excreted if a person drinks seawater. Considering osmolarity comes to around 1000 milliosmol per liter. So now they've given the value also, and the maximum ability to is 1200. So this comes to 1.5 liter as we had discussed earlier. Which of the following statement is false? Vasa recta acts as a countercurrent exchanger. Yes, true. Countercurrent mechanism provide osmotic gradient. So the whole purpose of countercurrent mechanism is to provide the osmotic gradient. Sodium ions play a major role in interstitial medullary osmolarity. Yes. So that is another thing I've seen in many questions. Your sodium, potassium, chloride. The most important one is your sodium ion, which is there. Okay. There are other, in the distal segment also sodium chloride exchanges are there. Then countercurrent exchanger is involved in generating osmotic gradient. So countercurrent exchanger maintains the osmotic gradient. Countercurrent multiplier is what generates osmotic gradient. So that is a false statement. The main driving force for countercurrent multiplier is. So over here, lot of other things are there which all these help in creating a concentrated urine, yes. But to make the countercurrent multiplier, the main driving force for that is the reabsorption of sodium that is happening in thick ascending limb. So that is what ultimately the countercurrent multiplier does. Yes, so that's the answer. Urinary concentrating ability is increased by increase in renal blood flow. So increased renal blood flow means there's a lot of volume. So we don't need a concentrated urine in that scenario. Increase in GFR also generally means there is increased renal blood flow. Reduced medullary hyperosmolality, to make it more concentrated, the medullary osmolality should go from 600 to 1200. It should not reduce to 600 and go even lesser. So this is also not the answer. ECA volume contraction. So when the ECA volume contracts, that is when you need to concentrate your urine. Yes, so that is the answer for that. Substance involved in countercurrent mechanism for maintaining medullary osmolality. So you need sodium chloride, yes, you need urea, and you need water. So all these are involved in your whole countercurrent mechanism. Yes. In presence of vasopressin, the greatest fraction of filtered water is reabsorbed from which part of nephron? So this is sort of a trick question. Whether vasopressin is involved or it's not involved, the greatest fraction of filtered water that is reabsorbed is obviously from the proximal part, regardless of vasopressin. So the answer here is proximal tubule. So some people might get confused thinking that vasopressin acts on the collecting duct, so they might go for that answer, but that is not the scenario here. You just take a look at this diagram. You can see water, this is coming, and you can see that majority of the, like 60% of it is already gone in the proximal part. The remaining part lopophenly, and you can see how much collecting duct has. But this is where ADH acts. Remember that ADH acts this part, but majority of the fraction is already done in the previous parts. Okay, so that's it. Thank you.